Thank you very much, Layla, for that kind and warm introduction. And good morning. Greetings, everyone. It's truly a pleasure to be with all of you. As Layla stated, my name is Nadine Gracia, and I'm the President and CEO of Trust for America's Health. And it's such a pleasure to be here with you at the 11th Annual American Climate Leadership Summit. I truly commend everyone in the audience for your interest and your commitment to taking climate action. So we really have a great pleasure today to have this fireside chat with an amazing colleague who is steadfast in his work to address the climate crisis, and that is Dr. John Balbus. As you heard, Dr. Balbus is the Interim Director of the new HHS Office of Climate Change and Health Equity. Dr. Balbus and I are going to engage in a conversation, and we invite you to join us in that conversation through your questions and your comments. So let's dive right in. John, welcome. I know that you are no stranger to the American Climate Leadership Summit.
Thanks so much, Nadine. And yeah, let me just add my thanks to Equal America and the organizers of the summit today for giving us the opportunity to have this chat. And it's wonderful to see you and to be able to be here with you.
Absolutely. Well, John, let's dive in with the time that we have together today for this conversation. You know, as Layla mentioned and as we've introduced, you are now leading this new Office of Climate Change and Health Equity at the U.S. Department of Health and Human Services. You know, some may be familiar with it, some may not know much about the office. Can you tell us about the office and what are you aiming to accomplish? What is the office really striving to achieve?
Sure. So, very briefly, the office was one of the mandates given to the Department of Health and Human Services by Executive Order 14008, Tackling the Climate Crisis at Home and Abroad, which did an array of activities related to climate change and also very much embedding that with environmental justice. We've been around since August. And, if I were to frame what it is that we are about the power of health mainstreaming. This is the mission, that we have as an office. Prior to the establishment of the office, the only dedicated budget item within HHS related to climate change was the CDC Climate and Health Program, which is a really fantastic program. It has supported, the nation's state health departments, the city health departments, and doing vulnerability assessments and initiating adaptation planning. It was relatively limited in its size. It didn't grow much beyond $10 million a year. And it was very much located within the world of public health, which is a great starting place. But with this office and with the mandate of the Biden administration, we really have this opportunity to get to not just the world of public health, but to 10% of the entire U.S. economy, which is what the health sector represents. Mobilizing the healthcare delivery side of the HHS equation and also mobilizing the human services side of the $1.6 trillion organization that HHS is, has enormous potential for not just raising awareness, not just understanding the impacts, not just assessing vulnerability, but to actually address the climate crisis on the ground. The health sector is estimated to be about 8.5% of the nation's greenhouse gases. Excuse me. And so if we can address that, it's not just a big chunk, but it's also enormous symbolism of doctors, nurses, the health sector, not just taking care of patients, but taking care of the planet and taking care of their own emissions. The other big side of health mainstreaming is that right now, as we are still in the throes of the COVID pandemic and really focusing on how do we emerge from this, build resilience, build back the well-being and the ability to thrive in our communities, especially those hardest hit by COVID, which not coincidentally are exactly the same communities that are suffering the most from climate change and likely to continue to bear the brunt of climate change impacts. Being able to demonstrate that alignment and tap into the resources and show how those resources that are being mobilized to address fundamental health disparities, and looking at the social determinants of health, is really at the cornerstone. It's been at the cornerstone for climate change adaptation for health for many years. We need to, the more we can do to reduce health disparities, to reduce the prevalence of chronic health conditions like asthma, obesity, depression, anxiety, the better off everybody fares in the setting of climate change.
Absolutely. Such critical points. And John, you specifically spoke to that intersection, right, with regards to equity and climate change and environmental justice. There's intentionality there. I mean, the office's name is of climate change and health equity. Can you drill down even further with regards to the importance of the work that you are engaged in bringing together that intersection of equity, social determinants of health, environmental justice, and climate change? What opportunity does that bring to really see some significant change and movement as it relates to the climate crisis?
Sure, thank you. Let me give you some idea of what I'm talking about, what mainstreaming of climate change in health looks like. And we're using a framework. I'm borrowing this from my colleague Joe McCannon, who's working with me, of signaling, support, and standards. That ultimately we need to make sure that our policies and our resources are really aligning. But in this first year, we are also making sure that we're signaling that we're here, that HHS as a whole is coming to the stage. So some of the things that this looks like, there are now, there are, in the government, in the bureaucratic machinery of the government, the first thing that often happens is a request for information. So we've had a request for information from NIH for the first time to really get the research side of what's going on with climate change and health. Our office has been working with the Agency for Healthcare Research and Quality, which is the other big research arm and tools arm of HHS, but more focused on the healthcare delivery side, more focused on the actual on-the-ground implementation of healthcare delivery. And they have an RFI that's come out that we're helping to analyze. And then the big ship within HHS is, of course, Medicare and Medicaid. The elderly population is a vulnerable population. The Medicaid population serves the poor, low-income population of the United States, which is the population that those are the two populations that suffered the most with COVID, that are at the front lines of vulnerability to climate change impacts. And so we have been working with them in their rulemaking process to incorporate climate change and health equity into their first signals, into the notices of proposed rulemaking. One of those has come out already within the payer rule, and as the rules come out, we're hoping to be able to work with them on that. One of the areas where we're building this collaboration, and I mentioned it briefly, is the focus on social determinants of health. This is something that's going on throughout the mainstream of HHS, is recognizing that the recovery from COVID has to address the upstream drivers. And those drivers, are rooted in racism, structural problems in our history, historical trauma that persist in many communities in the form of degraded built environments, degraded social structures, degraded resources and availability. I would say that if you look at what has gone on so far with social determinants of health, even though they show a slide of what the social determinants of health are, it includes the natural and built environments, there's been almost no operationalization of that. And that's what we are starting to do. We're starting to convey the importance of access to non-motorized transportation infrastructure, of green space, of reducing impervious surface, which creates heat islands, which reduces nature contact, which leads to increased flooding, all of these things. We're showing that alignment, that intersectionality of the social determinants of health, not just the natural built environment, but of course, safe housing, healthy food, all of these things are part of climate resilience and part of the actions we are taking for climate mitigation. Plant-based diets, which have low carbon footprints and convey all kinds of health benefits to reduce the chronic medical conditions that make people vulnerable to climate change impacts. The other thing I just want to mention, and there's a lot of things we're doing, we probably don't have time, and I don't want to just it's not a conversation if I'm just blabbing on about what we're doing, but we are in the midst of a very, very serious mental and behavioral and substance abuse crisis right now. And the Surgeon General has just released a report for the first time, the Surgeon General, in talking about the mental health and behavioral health crisis. And of course, we just had a wonderful video from the APA on the behavioral and mental health crisis. I just mentioned the Surgeon General's report, which explicitly mentioned climate change as an additive and an important component, especially for our children, adolescents, and young adults. So we're working very closely with the nation's behavioral, mental health, and substance abuse agency, SAMHSA, which is taking this on and starting to incorporate climate change as a stressor and behavioral health as a critical component of both the recovery from COVID, but also climate change resilience in the face of increasing disasters, in the face of increasing climate-related stressors to address that. So the bottom line is that we have been mandated to sit down one by one with each division of Health and Human Services that is on the ground serving our frontline communities. We have identified over 200 levers, 200 different initiatives, funded initiatives across HHS that are relevant to climate change and health. And we are sitting down with each agency. We are, in a couple of weeks, having our second convening of representatives of all the major divisions to discuss the plans, to discuss what will be incorporated into the next iteration of our climate adaptation resilience plan. But it's not just a plan. And I just want to emphasize, we're not just about creating plans, even though that's our mandate, that's our frame. It's really about the doing and about the mobilization of the resource flows and the action on the ground.
So for an office that just was launched last August, you have certainly had a quite ambitious and robust agenda of action. And you, importantly, John, talked about how, health is not only healthcare, and how you are truly reaching across and addressing both healthcare, public health, as well as human services sides, to recognize that as we think about the health and resilience, well-being of communities, it really has to have that type of multidisciplinary, multi-sectoral approach, which embodies, for example, the framing you shared with regards to the social determinants of health. How would you say, and your comments themselves really articulate this, but how would you say having this office is different than some of the other federal initiatives, administration priorities that have existed in the past? What is the opportunity that you see here in having this office, in addition to the concrete action steps you're saying you articulated? But how is this different? Because you've been working in this field for many years in climate.
Yeah, it feels like a new world. And the world is different because for the 12 years that I've been in government, climate change has been kind of encapsulated within the climate change and health program of CDC, and within, to a large extent, my home office, the National Institute of Environmental Health Sciences within NIH, although many institutes at NIH were doing some unsolicited grant funding in the climate change space. But it was an environmental health issue. And what's different is we're breaking out. And I have to say the breakout is frustratingly incomplete. This mainstreaming, we are just getting going. We're getting great traction. And I'm going to share a couple of other examples. But at the same time, for example, there's work to be done with the climate change community. So when something like E&E News writes about what's going on in the federal budget for climate change, they'll go agency by agency, and Department of Health and Human Services, all $1.6 trillion of us, will not be mentioned in that article. So what's different now is that at the highest levels of leadership, there is serious commitment to doing things within HHS, so that all of the divisions are stepping forward. All of the divisions can feel this opportunity, as we know there are a lot of people in and out of the federal government who want to be doing something. And so there's a lot of staff across HHS that want to be doing something, but they don't know exactly how to prioritize, where to start, what to do. So the creation of an office like ours of subject matter experts whose job it is to sit down with them. If we did not exist, every agency's busy. Every agency has their mandate. Our mandate is to work with all of them, to build the partnerships, to find the synergies. That is a blessed opportunity from my point of view. And it's a unique opportunity to actually move things. Just one example of what's going on, supported by the subject matter experts in our office, we have for the first time, the Assistant Secretary of Health is actually co-chairing an action collaborative under the National Academy of Medicine to decarbonize the health sector. Let that sink in for a second. That's a very high level official of the Department of Health and Human Services publicly taking a leadership role in climate mitigation for the health sector with the National Academy of Medicine. That kind of, first of all, there has to be an undergirding of support for that level of political leadership to be able to have a comfort level to take on that leadership role. But that symbolism then pervades I won't go through the acronym soup, but all of the pieces of HHS that work at community health, that work on aid for low-income families, the nutrition programs for low-income children, the programs for the elderly, they're all coming to us and the discussions are getting going, and we're helping to identify those things where they can actually make the difference too.
Really terrific, just your insights into how things are different and the importance of the partnerships and collaborations. And I'd love to talk about that some more. I'm going to bring in the audience here to some of these questions that we're having in this fireside chat. And one of them is around workforce. One of the issues, and this comes from one of the audience members, that they're hearing about in their state is a lack of workforce to fulfill the federal projects like weatherization, electrification, solar projects, and asking, how do we better address workforce needs? Funding is critical, but without workforce, the projects won't go forward. Your thoughts on that issue?
So, our focus is really on the health workforce and ensuring that the health workforce is aware of their role in building resilience and addressing the health inequities that contribute to bad outcomes and lack of resilience in the face of climate and health. And again, we are working to ensure that the enormous investments that Congress is making in public health and health workforce development are not just looking backwards at past problems such as COVID, but looking forward at the problems that we will be seeing, which could be another pandemic, but will absolutely be heat waves, wildfires, increasing floods, increasing forest fires, increasing hurricane severity, et cetera. So, we have one person working in our staff right now who has a foot in the California Department of Public Health and in our office. The state of California is training up 25,000 new community health workers to build their community health workforce. And this is an area where I'm very passionate. I think of, the health system in the United States as a kind of a Y, where we've got one branch of the Y that's public health and CDC, one branch of the Y is clinical healthcare, and everything from the essential and public hospitals and VA system up to the tertiary, quaternary academic medical centers delivering health. At the base of that Y, where those two things come together, I think are the community health centers that have this fundamental role connecting to the people most in need of health service and public health services, that play the role of delivering healthcare, but also connecting people to human services, resources, public health resources. And then, the base of that Y is the community. There has never really been a focused effort to engage the federally funded health centers and climate change to engage that space. There's a lot of interest there, but we have a public health emergency preparedness. We have a hospital preparedness. We don't have a community health center resilience and preparedness program yet, but we have tremendous investment in that infrastructure coming right now. And so we are in active conversations about training that workforce. I just came off a call we had with the Million Hearts campaign, which is just one piece that's really mobilizing healthcare delivery. The Million Hearts campaign has chosen to incorporate particulate matter air pollution as a critical stressor for the hearts of this country, if you will, that they need to address. We're sitting down with them to make the connection between health equity, exposure to transportation-related air pollution, the role of climate change in creating the air pollution, and the role of fossil fuel combustion in causing climate change and creating that air pollution. So those are some of the examples of how we're trying to mainstream awareness and connect people to the services that can build the resilience at the ground level.
Absolutely. And I really appreciate you raising that point about the community workforce, community health workforce, which is so critical, certainly in promoting health, as well as addressing longstanding inequities that we see in communities. We've got quite a few questions of interest that are around the task of the office that addresses assisting with efforts on reduction of greenhouse gas emissions, and some interest of hearing you speak just briefly a little bit more about how you're working to address reducing the greenhouse gas emissions by the health sector.
So this is an important part of our mission. It really was added to our mission when we went to COP26, the first ever official delegation of the Department of Health and Human Services. It was a very exciting moment. For me, I in the health component, I was nothing like an official delegation. I was just a guy going, trying to represent. But this time we were a delegation led by Assistant Secretary Levine, and we made a commitment to decarbonize, to create a low carbon health system in the United States. Of course, 90% of the health system in the United States is private, and the federal government has limitations in its ability to move that. So we are committing to mobilize the managers of federal health systems, and that's not insignificant at the Department of Defense, at the VA, but also the Indian Health Service that manages facilities, HRSA, Health Resources Service Agency. We have created a learning network and pulled together all of those managers of federal health systems to facilitate, catalyze, speed, support the implementation of decarbonization, which now is codified in another executive order that came out in December. But the National Academy of Medicine Action Collaborative, which just had its meeting yesterday, Admiral Levine addressed them as the lead of that, is taking up the work of a public-private partnership. It's a very exciting public-private partnership, a lot of power, bringing together leading health systems, bringing together the American Hospital Association, the industry group, bringing in the Association of Academic Health Systems, and many others, to create a space to come to agreement within this action collaborative about what are the metrics, what are the low-hanging fruit, if you will, in terms of what health systems can do to reduce their carbon emissions, to help us set that path together. And then, as I indicated, our strategic frame is signals, support, standards. Standards is a very long path when it comes to CMS rules. That's a 5 to 7 year path. The first step of that is engaging and signaling the community with the RFIs that I mentioned. The second step of that is starting to do the innovation and the creativity, the R&D in the health systems delivery side, which has never, ever happened in a meaningful way within HHS. That is going on. Medicare, Medicaid has a very substantial, hugely funded set of resources for technical assistance for the health systems in this country to assure quality, to assure health equity now, to assure that they're meeting the mandates and the standards that the federal government is providing. We are looking to start to tap into that, to start to bring the learnings that we might get from a National Academy Action Collaborative, and then start to support health systems, especially America's essential hospitals, especially the health systems in rural areas that are currently on the ropes from the COVID pandemic. One of the things that's really important is a recognition that achieving this, you can't just keep talking about it. You have to put funding and resources behind it. That hasn't happened yet, unfortunately, but we are trying to lay the groundwork where we have the infrastructure, we have the knowledge base, we have the structures for that technical assistance for health systems to start to move, and then we can start to find the financial incentives, the financial resources to do that, especially in those neighborhoods, in those areas where creating both, lowering on-site emissions, but also creating resilient facilities that have the power on when the power goes out elsewhere becomes not just a mitigation strategy, but in those neighborhoods where people may not have air conditioning, where they may not have a lot of backup systems, the health systems can be part of that resilience too.
Well, John, amazingly, we are already at the end of our time together for this fireside chat. And
our conversations always go too quickly.
Could always go too quickly, but certainly just commend you and thank you for your leadership and the commitment of your team to really this important office that has been launched. And just to leave us, how can our audience learn more about the work of the office if you want to share?
Thank you. Yeah, as a closing, I've only touched the surface of what we have done, and yet alone what is coming down the pike. And to know what's coming down the pike, please join our listserv. We have started periodic communications. Communications and engagement is a big part of what we're doing. We are working on the first ever seasonal forecast for health that will take the NOAA seasonal forecast that looks out a month. There's 90 days and what the weather's going to be and saying what that means for health. The way to get there is if you just Google HHS Office of Climate Change and Health Equity, go to our website, sign up for the listserv, you will be on the receiving end. And I hope everybody listening will do that.
Thank you, John. And thanks again to everyone tuning in today.
Thank you, Nadine. And yes, thank you, everybody who was with us.